Good evening, everyone. A hearty welcome to AORA 2021. At the outset, I would like to thank Dr. Vishali Ponde, Dr. T.V.S. Gopal, Dr. Sandeep Diwan, Dr. Bala sir, Dr. Satish Kulkarni sir for giving me an opportunity to be a part of AORA 2021. So, today, my pattern of lecture would be history, indications, a very quick anatomy, epidural space, equipment, technique, dural puncture epidural, drugs and additives, contraindications, complications, and summary. So I will be skipping through a few on drugs and additives due to time constraints. Now going back to the history, 1885, Leonard Corning was a neurologist. He performed peridural anesthesia using cocaine solution. Apparently, this was an accidental invention. In 1895, Catherine first used epidural anesthesia in sacral region, which is now called as caudal analgesia. 1939, Dogliot wrote a book on regional anesthesia and thoroughly discussed about epidural anesthesia. And in 1951, Crawford first performed continuous peridural anesthesia by means of urethral catheters. Now, indications, we all know there are many indications for epidurals. However, epidural anesthesia has been administered most commonly for procedures involving lower limb, pelvis, perineum, lower abdomen. It, it can be used as a sole anesthetic or as a complement to general anesthesia for a greater diversity of procedures. Now, let's see the quick anatomy. We all know that there are 7 cervical, 12 thoracic, 5 lumbars, 5 sacrum, which are fused, and 4 coccyx. Right. Now, let us spend some time on this slide. This is the spinous process here. This is the lamina. This is the superior articular surfaces. These are the pedicles. This is the transverse process, and this is the body. There are the three most important ligaments that we need to know is supraspinous ligament, then the interspinal ligament, and the ligamentum flame. So there's a mnemonic SIF SIF. So when the needle goes through, it goes through skin, superficial fascia, deep fascia, the supraspinous ligament, the interspinous ligament, and the ligamentum flame, and the space. You know, there are a few landmarks that we need to know as well. The most prominent cervical vertebra is C7. The inferior angle of the scapula is T7. The rib margin, which is about L1. The superior aspect of iliac crest is about L4, and the posterior superior iliac spine is S2. So we need to know about something about epidural space. Now here, the epidural space um, uh, surrounds the dura mater circumferentially and extends from the foramen magnum to the sacrococcygeal ligament. The space is bounded by the ligamentum flavum and laterally by the pedicles and intervertebral foramen, and anteriorly by the posterior longitudinal ligament. Right. So, of all these three epidural space compartments, posterior, lateral, and anterior, the posterior epidural space is the most relevant uh, clinically, and we all know that the 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 um, the space has a lot of adipose tissues. As you see here, a lot of adipose tissue, it has a lot of veins. So we need to be a little careful with this. Now, in this slide, you can see the dura mater, which is gray in color. A dark green is arachnoid, and you have the pia mater and the spinal cords. So just to get the overview of the spinal cord, how it looks. This is a very important slide where if you see here, this is the ligamentum flavum. So ligamentum flavum with different types of midline gaps. It may sometimes create a midline gaps. What is its importance? The ligamentum flavum midline gaps represent incomplete fusion of the right and the left ligamentum flavum. They are commonly in cervical spine and decrease in frequency from thoracic to lumbar region. The variable in thickness of the ligamentum flavum and the presence of a midline gaps may contribute the failure to identify the epidural space. So this is one of the reasons why sometimes the epidural fails. Now, distance of epidural space here. is in cervical, it is about 1 to 1.5 mm, whereas in lumbar, it is about 5 to 6 mm. The thickness of dura is very thin, that is 0.66 mm to 0.33 mm. Right. Now, uh, lumbar, that is the suggested level for the nature of the surgery is if you insert a catheter between L2 and L5, we can take care of hip surgeries, lower extremity surgeries, and obstetric uh, analgesia. Right. So now I will be skipping through this because if times permit me, I can come back. Now we need to know a little bit of the epidural catheters, the Tuhi needle. So we need to know about the equipment that we use for epidural. So now here, the Tuhi needle is about 10 centimeter long. It's 10 centimeter in length. It with the 1 centimeter graduations, it comes as 16 gauge and 18 gauges available. The tip is called the Huber's tip. The pediatric epidural catheters are also available with 19 gauge, which is 5 centimeter in length, with 0.5 centimeter markings are available. This available. There are other needles that we need to know. One is modified Tuhi needle, which is also called as Tuhi Husted needle, Ways epidural needle, Portex needles. Again, the Portex needles are color coded here, and blunt tip epidural needle. Now, epidural catheter uh, are made up of nylon or polyvinyl chloride. They are radio opaque. Catheter length is about 90 to 100 centimeter with markings of 5, 6, 7, 8, 9, 10, 15, and 20 from the tip. Catheter size are 16 gauge, 18 gauge, 19 gauge, and 20 gauge are available. Catheter diameter is anywhere between 0.9 for 18 gauge and 1.1 mm for 16 gauge, and they are also color coded. Dark blue is 18 gauge and light blue is 16 gauge, and so on. So, so coming to the technique of epidural, here the other most important thing is when we start a procedure, the most important part of the procedure is the skin preparation. Now there are two solutions that are commonly used. One is 10% povidone iodine, which is all recommended, and also chlorhexidine is recommended. Now chlorhexidine comes in two concentrations, that is 0.5% and 2% chlorhexidine. We here in India use 0.5% chlorhexidine. Now I will just show you how to clean the bag. Here on the right I'm using chlorhexidine, and here on the left I'm using betadine. The first paint with the when almost from the infrascapular line to the gluteal cleft. The same thing happens with the chlorhexidine. The second paint will be within the first paint. So within the first paint will be the second paint, and same way here with the chlorhexidine. In US, it's recommended to use 2% chlorhexidine, and in Europe, in Europe and UK, about 0.5% is what is recommended. 10% of iodine is equivalent to 0.5% chlorhexidine, but do not use 2% because it is much more neurotoxic. Yes, 0.5% also is neurotoxic, but 0 2% is much more neurotoxic. The first paint the bag with chlorhexidine and then start getting ready with your trolley preparation, and let the chlorhexidine dry up. Now, this is the local infiltration that we are using. In this scenario, I'm trying to find the epidural space. So I have taken out the whole towel because for the better visualization. And what I have done is I'm trying to feel the space, and I'm going to use a thin needle to infiltrate the space. The two things to remember here: when we use a lignocaine, it gives like a stinging, uh, pain. So what we do is we can use a levobutyl if it's available, but only thing is you need to wait. Right. Now, what are the different techniques used for epidural space identification? Yes, there are a few techniques that we need to know. One is loss of resistance to air, loss of resistance to saline, and loss of resistance to tactile. Loss of resistance to tactile will be dealt in the future slides. Now here, I'll be playing the videos here. So what I'm going to do is I'm trying to insert the epidural needle in the midline, and I take air and try to get a approach the epidural space by using a loss of resistance here. So what I'm going to do here is I'm going to get a loss of resistance to air technique. Right. Now we also use loss of resistance to saline. Now what I'm going to do is I have inserted the epidural needle and I've taken a saline here in my syringe. So I'm going as a one unit. The whole thing goes as a one unit. As soon as I enter into the epidural space, the needle empties its, right. That's the easiest way of doing it. So this is the loss of resistance to saline. So then I thread in the catheter. Yes. So next, there is something called loss of resistance to tactile. I always use the loss of resistance to tactile. It is much more easier. You have two patients here. We have one patient about 110 kgs, and we have a patient which back was not very well felt. So in this, I'll just play the videos. Here, I'm going here in the midline. I'm using a tactile to locate the epidural space. Right now, I'm in the epidural space. So what I've done is I'm not going to use neither the saline, neither the air. So I'm going to directly thread in the catheter into the epidural space. So this is nothing but loss of resistance to tactile. So same way, I have one more patient here. Again, this was a little difficult one where I could not elicit the proper space. So I had to take a couple of tricks. So then once I found, then I was in the space here. If you can see here, I could get that giveaway where I could pierce the ligamentum flavum. Then now once I get this, I thread in the catheter. Here you can see, now I'm going to thread in the catheter. Yes, right. So let us skip this now. And now what in this video, what I have done is here, the well, first I'm going to elicit a space by using tactile and then a saline just to open up the space so that the catheter goes in very easily. There is a technique called CSF technique. Okay, it is called as continuous saline flush. So let me play this video. Once I get into the space, I ask my colleague to push saline, and as I'm threading the catheter into the epidural space, I also push the saline so that if there are any veins or any tissue, it takes away from the catheter. So the chances of catheter getting into intravascular is very less. Right. Now, how do we fix this catheter? We use something called as occlusion clamps, right? So this is the one of the thing that is shown here. Now, what is the question that is commonly asked is how much length of the catheter to be left inside the space. The length of the catheter should be at least between 3 to 5 centimeters, right? Not more than six, right? 3 to 5. And in obese patients, you can leave about six, but not definitely more than six. Leaving a catheter more than six invariably gets into intravascular. Now, there is something called as dural puncture epidural. Now, what is dural puncture epidural? Dural puncture epidural is nothing but it is an emerging technique seen in labor analgesia. What happens here is after eliciting the epidural space, and when the epidural space is located with the epidural needle, a pencil point spinal needle is inserted utilizing the needle through needle technique, and the dura is punctured. After puncturing the dura with 25 gauge or 26 gauge, because using a thinner needles, the whole purpose gets defeated, and studies have shown no benefit. So after puncturing the dura, we take away, we do not inject any drug, right? After few hours, we activate the epidural space. So the logic is the drug that we are injecting into the epidural space can get into the subarachnoid space for a better block. So I'm going to skip through the slides here. Again, I'm going to skip through this. Yes, there are few contraindications. A few contraindications, absolute contraindications and relative contraindications. Patients refusal, severe coagulation abnormalities, and relative contraindications are elevated intracranial pressures, thrombocytopenia, anticoagulants, severe sepsis, central nervous system disorders, needle placement through the tattoo. Right. Now, again, the complications of epidural blockade can be classified broadly into drug or procedure related. Potential drug related complications include allergic to local anesthetic, direct local local anesthetic induced nervous tissue injury, and procedure-related complications may be mild to moderate or transient. Back pain, pneumocephalus if you're using as air as a loss of resistance technique, and PDPH. Potential life-threatening complications include subdural injections of local anesthetic, total or high spinal infections or aseptic meningitis, cardiac arrest, epidural hematoma formations, and permanent neurological injuries. To conclude, to conclude, always ensure patient's anticoagulation status before the procedure. Back pain is a common post-operative complaint. Dosing of the epidural catheter, always do it in allocoids of 3 to 5 ml. Limit the depth of the catheter insertion of less than 6 centimeters, as I was mentioning. Beware of epidural hematomas. So with this, I would like to conclude my talk, and thanks for your kind attention.